Okay, good evening everyone. Yeah, sorry for a bit late. So we're going to start soon. So we will start with first. Today we will have four BCC by three candidates. So the first candidate will do one, second will do two BCC, and the last one will do with the remaining one BCC. So Yi Hong, are you ready? Emma, you can start now. So only 2 minutes, huh? Okay, 2 minutes up. This is Madam Palmer. Please start.
All right. Good evening. May I confirm that this is Madam Palma, 36-year-old?
Yeah, Madam Palmer.
Okay, Madam Palma, this is Dr. Lee here. I'm the doctor at the clinic. Today I would like to ask you a few questions and examine you at the same time. Would that be all right?
Okay, sure.
Okay, Madam Palma, I have my attention that actually you come to the hospital because of you have this excessive hair growth. Can you tell me more about that?
Yeah, doctor. I've been noticing that I grow much more hair, especially over my face, neck, and also my chest. For the recent 6 months. Sometimes also at my back also I feel my hair actually grow easily, and you can see here I also have a lot of this acne. I don't know what happened, doctor.
All right, and the acne is new as well. Am I
Yeah,
correct?
yeah, yeah,
Is this the first time you have all this?
yeah. First time. Previously I don't notice this.
And does the hair fall easily? The new hair?
Not really. It actually grow a lot. I have to keep on shaving and also cutting the hair.
All right, okay. So I would like to ask a few more questions regarding your condition. Before that, is your menses regular?
Unfortunately,
You-
my menses is not very regular. Sometimes I miss my menses.
Okay, and usually, at what age do you start to have menses?
I start to have menses about 12 years old, and in the recent 1 year, I noticed that my menses sometimes on and off, only skip 1 month. Sometimes maybe up to 30, 35, 37, 35 to 40 days, only come once.
Okay, and usually how many days the menses will last?
It depends. Sometimes it only lasts 1 to 2 days. Sometimes also lasts up to 7 days.
Okay, do you realize that this acne actually worsen when you have the menses?
I'm not sure whether related, but the acne for the past 6 months have been worsening. I can see a lot
All
of.
right. All right. So sorry to hear that. It must be very troubling for you. Let us see
Yeah,
how we
yeah.
can help you here. All right. Besides that, do you feel like you prefer cold weather than hot weather? Any weather preferences?
No, I think it's the same for me.
All right. Any change in your weight?
I think I have gaining a bit weight. I have about 3 kg compared to 2 months ago. Gaining
All
more than
right.
that.
How about your appetite? Any increase in your appetite?
My appetite is still good.
Your appetite is still good. All right. All right. Sorry to ask, do you realize that actually your shoe size has been increasing?
No, no,
Okay. Any change in your finger sizes, or do you couldn't manage to put any rings that previously you were able to do so?
no, no.
Okay. And previously, just would like to ask some sensitive question. Do you have actually have been having pass out some milky discharge from your back breast? So sorry to ask
No,
sensitive this.
no, no, no.
All right, all right. So sorry again, just about the menses. When was the last time you have your menses?
I think 2 months ago.
2 months ago. All right. Any past medical history that do you have any medical condition that previously you had?
Yeah, I have diabetes.
All right. And how many years you have this diabetes?
Actually, only diagnosed by my GP about 1 year ago.
1 year ago. And what medication that you are on?
My GP actually only tell me to take metformin if needed, but actually I've not been compliant.
Okay. For your diabetes, have it affected any of your eyes? Do you have any blurring of vision?
I have checked my eye last year. It was told to be normal.
Okay. How about the kidney? Did the doctor tell you about any problem with your kidney?
Kidney is okay. The doctor told me.
All right. Do you know what is your latest HbA1c?
I actually only went for an appointment once. I didn't check for that.
All right. All right. Okay. Any surgical history? Any
No,
operation before? Any
no.
allergies?
Not allergy, but I have been having skin itchiness for many years. The doctor told me I have this eczema. So they started me
Eczema.
on steroid cream uh, about 2 times per day. And I also require this medication called cyclosporine.
All right. May I know why you are taking cyclosporine for your eczema?
Yeah, yeah, doctor told me my eczema is quite bad. I have to take this medication.
All right. Any recent change in the doses of the cyclosporine?
No, it has been almost 3 years now. I've been this medication is about 50 mg twice per day.
I see. All right. Okay. So, but the cyclosporine has been for 3 years, but your symptom of excessive hair growth only for the past 6 months. Am I correct?
Yeah, yeah.
Okay. Sorry to ask. Are you smoking?
No, no, I don't.
How about alcohol intake? Do you take any alcohol?
No, no.
All right. Sorry. Are you married?
Yeah, yeah, I'm with my husband.
And how many children do you have?
We have been difficult to have any children, unfortunately.
All right. So, Madam Palma, I would like to examine you. Would that be all right?
Okay, sure.
All right. I would like to check that the arm. Looking at the vital signs, her vital signs are all stable. Any sweaty palms?
No sweaty bumps?
Any signs of acromegaly, for example, spade-like hand or
2 minutes
even
left?
fingers? No.
No.
All right. Okay. Quick look about the face and also any check the eye, any vision problem,
Vision problem? Or what you want to check in the eyes?
visual field, any
Visual field
visual
is, as I told you, normal.
normal. Okay. Any murmur?
No murmur.
Okay. Madam Palma, may I know what will be your concern?
Doctor, what am I having?
All right. So, Madam Palma, based on the history and also what I have examined, I think you have this problem called polycystic ovarian syndrome. Don't be worried about the term. It basically means that your ovary, because of your diabetes and also your body condition, your ovary is producing more hormone called androgen hormone, which can actually cause the symptoms that you're actually having, which is the excessive hair growth, diabetes, and also the acne. So for this condition, the main treatment will be weight reduction and also control the diet and also have a good control of your diabetes. However, if everything fails, actually we will have to start use on some treatment. Then also it will get better with
Okay.
the treatment.
Doctor,
Yeah.
can I have children later on?
Yes, you can have. However, because you are on this medication called cyclosporine, it is rather safe in pregnancy, but we do have to monitor you better and earlier. In PCOS, patient might have difficulty in conceiving if the condition is not well treated.
Okay. Is it how do I reduce this hair growth? It has been very troubling me.
Okay, for the hair growth, actually once the treatment started, it will improve.
Okay,
However,
time's out. Thank you, Dr. Lee. Okay,
all right.
Dr. Lee, can you tell me what is your diagnosis and differential for this patient?
My diagnosis for this lady will be likely hirsutism secondary to polycystic ovarian syndrome because the patient actually has acne and also she has irregular menses and have problem with her fertility. In addition, she also have diabetes mellitus as well. All these
Okay.
actually point towards a PCOS. However, bear in mind that she actually taking cyclosporine as well, and cyclosporine can actually induce hirsutism. But again, cyclosporine was started 3 years ago, and the hirsutism only started 6 months ago. So it is less likely, and there's also no recent changes in the dose of the medication.
How about any different other differentials?
Other differential will be hypothyroidism, in which this patient is likely doesn't have, and also possible is the tumor, a pituitary tumor, which I actually kind of rule out with no signs of prolactinoma and
Okay.
also no
How will you
evidence of
investigate this patient?
I would like to investigate this patient with full blood count and the blood test, and also most importantly for this will be a hormonal test, and also I would like to do an ultrasound to look at the ovaries. Will there be any, because the triplet, as the name says, is a polycystic ovarian, so I will have to check at the ovary as well to look at the polycystic, and then I would like to check the sugar control, which will include HbA1c and also potential diabetes complication for this patient. Yeah.
Okay, how will you manage?
Management wise, as mentioned, it will be a non-pharmacal treatment mostly. It will be weight reduction, healthy lifestyle, and also rule out other possible causes. And also, I can actually send a TDM cyclosporine just in case that actually it's not overdose.
Okay, all right. Time's up. Okay, thank you. Yeah, how do you think?
I think I didn't complete all.
Complete as in examination or the management?
Yeah, a bit rush at the back.
A bit rush, because I think maybe because you start as first station and then as the first candidate, so the pace itself is a bit slow initially.
Yeah.
But I think you managed to catch up quite fast, especially towards the 5 and 6 minutes. You realize that you need to examine patient, and right
Yes.
before 2 minutes left, you managed to examine patient. But generally, you still need to be a bit fast. And then you asked to check for the neck and the neck, is it just now when you want to mention before the 6 minute?
Yeah, I actually want to check the neck also. Any
Yeah.
next thing.
Yeah, and you may also want to check for the armpit as well for acanthosis nigricans, right?
Yes.
Yeah, for this kind of patient, you really need to ask for BMI lah, because definitely weight gain, and we need to know what is the BMI. So and yeah, probably we'll go. I think you got the diagnosis all correctly, which is good. Probably the investigation part, the hormone panel. If you got more time, how will you mention what hormone profile that you want to send for this patient?
Basically, PCOS need to check for FSH, LH, which is the main profile and androgen testosterone level androgen level, because it is mainly androgen that causes all the hirsutism
So it's a FSH, LH to look for the ratio, free
Yeah.
androgen index, total and free testosterone level, androgen including the 17-hydroxy progesterone So have to mention that. And then you may also want to rule out Cushing, right? You want to rule out when you do a 24-hour urinary cortisol and consider dexamethasone suppression test. And this patient should also actually ask to check for UPT as well. We never know, patient try quite hard yeah, and pregnancy also sometimes can also cause this
Cause
insulin
hirsutism.
resistant. Yes, correct. Good. So we will go to the discussion now. I think your approach is quite fast. The moment you recognize that this is hirsutism, got acne, you didn't waste more time to ask about the hair, whether any change. But the only question you ask is useful is whether there's any hair loss instead of just hair growth. And then you also ask about period, very fast, good. And you ask about comorbid, which is diabetes and the eczema. So the cyclosporine here is something additional just to make as a differential diagnosis. Yes, and as a red herring, sometimes a lot of scenario we have some red herring. We need to decide whether it's important or not. And then yes, you want to say that the patient has hirsutism, want to mention that, and then want to check for, you have tried to check for visual field to look for any Cushing disease or acromegaly. And I don't know why you suddenly check murmur. Any reason?
Because I thought of maybe some high output failure.
High output failure, like what? Carcinoid? Yeah, I was a bit stunned when you mentioned murmur, because to me, probably more important thing is abdomen for her.
Yeah, outbreak for
to
any
look for
masses.
any. I mean, usually we won't expect to have mass, but adrenal mass is something we had to kind of like just showmanship feel for it, although it's unlikely to have any palpable mass. Yeah, but another differential analysis is just not induced cyclosporine. And anabolic steroid is something that we should also ask. I realized you didn't ask that during the
Yeah,
medication,
didn't ask.
but probably it's a bit
Maybe.
rushed for you. Yeah, make sure that patient is not taking any extra steroid from anywhere, like traditional medication. The steroid cream usually will not have much systemic effect, but it's the one that, let's say patient try to seek alternative medicine, then maybe there is some steroid component there. Otherwise, I think you cover most of the thing. Another thing is, actually I didn't manage to ask you in terms of concern. what other long-lasting hair removal methods you know? It's actually these two are actually mentioned in the NHS website lah. I didn't list it out just because of knowledge purpose. But this is something if something is listed in the NHS website under patient leaflet information, then I suppose it's something that we should counsel the patient and we are expected to know. So electrolysis or even laser therapy is something that we can offer, because or else it's troublesome. For that you have to really shave every day. I have encountered a few PCOS patient that really troublesome. They every day also, like, I think guys also we not shaving our head that frequent. I remember there's few patient that I encounter actually have to shave every morning. Can be very troublesome. So that's why if let's say the patient asks for any better option to remove the hair, then you can offer to do this electrolysis, either electrical therapy or laser therapy to remove the hair, so that the hair will not grow up faster. And then another thing is that weight loss, yes. And you can also offer this iflornithine cream, which is also mentioned in the NHS website, to slow down the hair growth. But it only works over the face, not at the rest of the body. And OCP, if let's say patient is not pregnant and not yet achieved menopause, generally patient need to start on metformin. And if I got time, actually can I have children later on? Most of them, they are subfertility and they will require some form of infertility assessment. Yes, clomipene citrate is also one of the medication that can help with that, to induce ovulation, because they tend to have end ovulatory cycle. Okay, so this is just a approach on hirsutism. I realized that my notes didn't have this, because when I prepare for my exam I never encounter this kind of scenario. But again, I realized that this is something that probably is quite important for us to have a differential and approach in our mind. This is a scenario of hirsutism, excessive hair growth. I think we are encountering a lot of alopecia, excessive hair loss. So this is something opposite. So I've thought of just sharing everyone so that you all can have a list of useful differential diagnosis. First, hirsutism differential analysis to exclude is actually PCOS. Another one is other endocrinopathy, especially Cushing, acromegaly, hypothyroid, and polytinoma. I can see that you exclude these four in your history. Very good. Now you asked about abnormal breast secretion also, which is like, wow, okay, I didn't expect you to ask that. And the drugs as well. So you ask about, you try to elicit that. And let's say patient has seizure, sometimes phenytoin, one of the rare side effects is actually hirsutism, can happen. Same goes to the cyclosporine, as we all know. And then endogenic steroid is something we need to ask. And ACTH producing tumor is also something we need to be aware, especially most of the time they are not in the lung, they are not in the adrenal gland. They are in the ovarian or lung cancer. So it's more to the older age group. So if the older people came in with suddenly hirsutism for few months, and then chronic smoker, we need to think of whether can this be small cell lung cancer with ACTH as a paraneoplastic manifestation. Okay, and the last one but not least is non-classical CAH. So this one is not, this list of differential diagnosis is not developed by me alone. It's basically I looked through the NHS website in terms of the hirsutism approach as well. So they have mentioned this non-classical CAH, which surprised me, because I never thought that CAH maybe can be fulfilled. This usually is in pediatric age group, but non-classical, like partial 24 hydroxylase deficiency, they can manifest just like Cushing, just like PCOS. So that's the reason why we need to also have a put this differential as a back of our mind, especially when we are lack of diagnosis anymore, because this one they tend to be very mild in terms of symptom and cannot really differentiate much from other condition. So that's why only the 21 hydroxylase we need to check, and then only then we check the level is low, then only we realize this is another possible differential. So the PCOS diagnostic criteria is the Rotterdam criteria, 2 out of 3. So hyperandrogenism, which often manifests as hirsutism, and then oligo or end ovulatory cycle, and the third one is actually the polycystic ovary. I don't think we need to know the criteria of the how many follicles and how much the volume, but for us to these 3 alone is enough, and this patient actually fulfill these 2. So the patient actually have PCOS. Anyone have any question? You're okay, like you? Yeah. Probably the problem with you is maybe the timing itself. Sometimes it's difficult because when you start, so again it brings up to the point that if you are the candidate that start with the first station as BCC, then you will need to tell yourself again and again before you enter the room, you need to be fast. You really need to be fast because the first station is often the when we kickstart our engine, just about very fresh already want to go in, and then our pace may not be on par, and then sometimes we may be a bit panic, especially when the time is constrained. I hope that the new format in dietary will be better because you got more time, then you just take your time and then just do like how we used to do for station 2 for history taking. Halfway then you go and examine patient. I feel that is better. Okay, so we will proceed with second candidate if no question.
All right, thanks.
Okay, thank you. Okay, so second candidate is Abigail, right?
Yeah.
Yeah, have you ready?
Yeah.
So I will give you 2 BCC like a real exam. So you will have 5 minutes. I will give you 5 minutes. So your times begin now. Okay, time's out, Dr. Abi. Let's start. So this is the patient, Mr. Brad.
Good evening, Mr. Bra. Your doctor here today in medical clinic. I would like to know, I come to know that you have this shortness of breath for the past 4 months. Do you mind telling me more about that?
Yeah, I'm Brad here. So I've been having these breathlessness when I try to walk or when I try to do any exercise. This thing has been going on for almost 6 months and it's gradually become worse.
May I know how does the shortness of breath start? Is it started suddenly or gradually?
Yeah, it started gradually. So I wasn't having any breathlessness until 6 months ago, and I feel it's getting worse. If I lie down, if I'm not doing anything, I don't feel any breathless.
Do you take anything when you feel breathlessness that will make it relieve the breathlessness, such as you're taking any pump, any inhaler?
No.
Okay. How about, is there any cough?
Any what?
Cough.
Cough? Not really.
Any cough out of blood?
No.
Do you have any noisy breathing?
No.
Is there any changes over appearance of your nose?
No.
Okay. Any history of smoking before this?
No, I don't smoke.
Okay. How about, do you have any allergy to any food or any dust or any pet?
No.
May I know what do you work as?
My job, you mean?
Yeah.
Yeah, I work as programmer. I have been lacking sleep recently due to work.
Okay, do you have any exposure to any dusty environment before this?
No.
Do you have any fever?
Fever, I'm not very sure, but sometimes I do feel my body temperature is slightly warm. I never check my body temperature.
Do you have any chills and rigors?
No.
May I know if you told me that you have this warm in temperature. May I know for how long is that?
On and off, sometimes I'm not very sure. So probably about few weeks, like 3 to 4 weeks like that.
Do you have any loss of weight?
My weight has been quite static though.
Loss of appetite?
No.
Do you have any lumps and bumps anywhere?
No.
Do you have any, do you travel to any place before this?
No.
Okay, may I know, is there any medical history you have?
Yeah, doctor, I have reflux in the past. I also have cystic fibrosis and I have underwent double lung transplant 2 years ago.
May I know what medication you are on for for all these conditions you have?
So I'm on prednisolone 10 mg every day, once daily. I'm on MMF 1 gram BD, also on tacrolimus 3 mg OD, and also cryons every 3 times per day when I take meals.
Okay, may I know, is there any changes of your medication recently?
No, there's no changes in medication.
Are you taking the medication regularly every day?
Honestly, I do miss some medication, especially tacrolimus.
May I know the reason you miss it?
Yeah, like I said, I'm very busy with the work, so sometimes I forgot to bring the medication to work, and I only eat in the morning, and then the other sometimes I didn't take.
Okay. May I know, is there any other medication you are taking other than the one that you have told?
No other.
Okay. May I know, do you feel any fluid over the back of your throat?
No.
Okay. Do you have any runny nose?
No.
Blocked nose?
No.
Can I examine you?
Yeah, sure.
Yeah, so I would like to check the patient, to check for any anemia.
No anemia, no conjunctival pallor or palmar-pierce pallor.
Then I would like to check for any limb adenopathy.
Limb adenopathy, when you check the cervical lymph node, there's no palpable cervical lymph node.
Okay, then I would like to listen to the lungs.
Okay, this is the patient chest. You want to listen to the lungs. Which part of the lungs?
On both sides,
Both side. Okay,
from up to down.
up to down. So breath sound is equal both side, and there's no crepitation.
Okay, how about any bronchial bleeding,
No bronchial breathing.
vocal resonance?
Vocal resonance is equal both side, up and down.
Okay, then I would like to check for the tummy, abdomen, sorry,
Abdomen
to
is
look for
soft, non-tender.
any liver.
No palpable liver.
Then after that, I would like to, may I know, before having this shortness of breath, do you experience any fever before this?
Like I said, no obvious fever, but doctor, 6 months ago, I was admitted to hospital because of some lung infection, and they give me some antibiotic. After that, resolved already.
Okay, is it very frequent for you to get this lung infection after the lung transplant?
Yeah, the transplant was 2 years ago. The infection is only 6 months. That time was my first time admitted for infection.
So you only had one lung infection after the transplant.
Yes, yes. 2 minutes left.
Okay, Mr. Brad, may I know what is your concern?
Yeah, doctor, does it mean that my lungs are failing?
From our brief conversation and the brief examination that I did on you, I think this is one of the possibility. However, in view of you are having this multiple medication that can actually suppress your defense system, you are actually prone to have another episode of infection as well. So yeah, I think I would like to admit you to the ward because your oxygen level is not that good and you have a mouth high in temperature. So
I see. Do
I
I
think it's
need
best
do
for
I
you
need
to be
another
admitted.
surgery, doctor?
Before confirming whether your lungs is functioning well, I need you to be admitted first so that we can have a thorough checkup for you.
I see. I'm also having this reflux symptom when always feel bloatness, and sometimes when I wake up in the morning, I got this brushing kind of sensation over back of my throat. Can this worsen my lung condition?
This usually the reflex condition that you're having is unlikely to worsen your condition.
Okay, doctor.
Yeah. Is there any question for me?
No, no more. You got 20 seconds left? Okay, we can start the discussion. Okay, Dr. Abi, can you tell me what is your differential diagnosis and your most likely working diagnosis?
My provisional diagnosis for this patient would be a new episode of lung infection as the patient has history of lung transplant 2 years ago and is on immunosuppressant and presented with low blood temperature as well as hypoxia.
Okay, any other differential?
The second one would be failure of lung transplant or any transplant rejection.
Rejection. Okay, any other differential?
Any side effect from transplant such as any malignancy.
Which is?
For his case, any like skin cancer,
Skin cancer.
lymphoma or leukemia.
Okay, alright. How will you investigate for this patient?
So I will I will do a full blood count to check for any increase in white blood cell and CSR, CRP, and I would like to take a blood culture. If the patient has sputum, I would also like to request for sputum culture, sputum for ASB, and TB culture.
Any
Then I
other
will
thing?
do an ABG.
Okay, good.
Then I will do a chest X-ray, CT scan. Yeah.
So, patient told you that he is not compliant to the medication. Is there anything else you want to check?
Yeah, the level of the
What level?
tacrolimus.
Okay. And how do you confirm whether, let's say this is a rejection, how do you confirm that?
Maybe from the, I have no idea.
Okay, never mind. How will you manage this patient?
So I'll manage this patient in multidisciplinary approach. I would like to refer this patient to a CTC surgeon as well as respiratory physician. So at first I would like to, if the patient has any infection, I
Okay,
would like
time's
to
up.
stop the.
Time's up. Okay, so you may proceed with the next station. Next station is, what was the name again? Yeah, so next station is Mr. Edison. You may start now.
Okay, good evening, Mr. Edison. I'm your doctor here today in medical admission unit. I come to know that you have loose stool for the past 5 days. Can you explain more about that?
Yeah, doctor, I've been having loose stool for almost 5 to 6 days already lah. So it actually started gradually and it persistent and now it's getting worse. So I pass out almost about 5 to 6 times of this loose stool every day.
May I know, is this the first time you're having this loose stool?
Yeah, first time.
May I know, did the loose stool come with any particular food that you have eaten, such as wheat or rice?
No, it doesn't. It doesn't matter what diet I'm taking, but I realized that if I try not to eat, then the loose stool actually getting less.
Okay. May I know, in a day, do you know what is inside there in your loose stool?
Just brownish. There's no blood or any slime. No, just blood. Sorry, just brownish stool. No blood.
Okay. Is there any changes in your bowel appetite?
Bowel definitely for the past 5 days. My appetite also reduced recently, because I feel very discomfort.
Do you have any loss of weight?
I'm not very sure. I've been staying in nursing home for quite some time, and the caretaker has been giving me every three times per day of the meals. I've been taking that.
Is there anyone in the nursing home that is sick as well?
I'm not sure. So far, I haven't heard of anyone.
Did your nursing home caretaker did they bring you to visit some GP before this?
Before this, yes, I think 1 week ago I was sent to the GP because when I pass urine, it's a bit painful. So the doctor thinks that I have a infection in my urine system. So they give me an antibiotic for 1 week.
Oh, may I know the name of the antibiotic?
I think it's called ciprofloxacin.
Did you complete the dose?
Yeah, I've completed.
Okay. So how is your passing urine now?
Good. I don't feel any difficulty or pain anymore.
Okay. Do you have any fever?
No fever now.
Okay. Do you have any traveling history recently?
No. I only stay in the nursing home.
Okay. So Mr. Edison, I would like to examine your tummy.
Okay, sure.
So I would like to check the patient whether there is any mass or bubble over the tummy.
As you feel the tummy is soft, actually there's mild tenderness over the epigastric area, and when you auscultate, there is a hyperactive bowel sound.
Okay. Then I would like to check for any organomegaly.
No organomegaly.
Then I would like to check patient for any anemia sign.
No anemia.
Okay. Then I will auscultate the lungs.
Lungs, examiner tell you is clear, you can skip.
Okay. So, Mr. Edison, may I know what is your concern?
Oh, doctor, why am I having this persistent loose stool?
Mr. Edison, I think you are having loose stool likely due to the antibiotic given by the GP before this.
Oh,
Yeah, the condition due to the antibiotic, and in view of you having a very fast heartbeat and your BP is at the borderline, it is best for you to be admitted to the ward.
oh, I need to be admitted, doctor.
Yes.
Oh, okay. Then okay. So can my family member visit me in the ward later on?
This condition is actually an infectious condition, so it's better for your family member not to visit you, and you will be nurse. You'll be given an isolation room, in the ward.
Oh, why I need isolation, doctor?
Because this condition is actually an infectious condition and it can spread to other healthcare workers as well as other patients in the ward.
So minus
Yeah.
1 minute for examination, you have 2 minutes left now.
Is there anything else that bothering you?
No, I think that's all for now. I have no other issue, no other
Okay,
concern.
how about, do you smoke?
No, I don't smoke.
Do you drink alcohol?
No,
Is there any family history of gut cancer?
no.
Okay.
30 seconds left. Okay, we will proceed. So, Dr. Abi, can you tell me what is your provisional diagnosis and differential?
My provisional diagnosis for this patient would be Clostridium difficile infection, as evidenced by acute, acute episode of loose stool, as well as with history of antibiotic usage 1 week before this. And he has no any constitutional symptoms suggestive of any malignancy.
Okay, what are other differential diagnosis?
Other differential diagnosis would be other infective causes of this gastroenteritis.
Okay, any other differential?
Maybe no, not that I know of.
Okay, how will you investigate for this patient?
So I like to admit patient, and I like to send a full blood count, ESR CRP, as well as stool culture and sensitivity, stool or OVA and cyst. And I would like to
You have mentioned C. diff associated colitis. How do you confirm that?
toxin level.
Toxin level as in? Okay, never mind. How will you manage this patient?
I would like to admit this patient to the ward, and if the patient is in the state of dehydration, I would like to start the drip for the patient. And for the management of CD toxin, I would like to give vancomycin to the patient.
What kind of oral or IV?
Oral.
If it's not improving, then what else you can give?
Metronidazole.
Okay, IV or oral?
IV.
IV. Okay, time's up. Okay, that's all. How do you feel?
Stressful.
Sorry, again?
Stressful.
Stressful. Okay, definitely not something I'm expecting to hear. Okay, so I believe you have attended mock before, right?
Yeah.
Yeah, but is it the same feeling or is something worse?
No comment.
No comment. So sometimes when you encounter any cases that is a bit unexpected, never encountered before, or cases like very straightforward, you tend to be very off. We may lose ourselves in the exam. Then therefore you may become very panicked. At the same time, you may feel underprepared or even didn't do well. But actually, I feel you did quite okay for the first case. But But for the second one, a lot of things are missed. The moment you can finish BCC by 5 minutes and got no other question to ask already, it means that you are missing something. You know? Because we cannot be finishing BCC without, with so plenty of time left. So meaning to say that there's something that you miss from the history and there's something you miss from the examination. So I just want to go through the first case. So when you prepare the scenario outside, what is your impression? You don't know anything, right? What do you realize?
I only know this is a lung condition because of SpO2.
Your SpO2 slightly on the low side, right? Otherwise, temperature also like borderline like that, but not really fever, right?
Yeah.
Yeah, you're focusing more on the lung condition. Okay, correct. How about this acute diarrhea thing? When you look at the outside,
Outside is tacky and the BP is borderline. What I wrote is infection, inflammatory, traveling, and some tumors, maybe colon CA.
So another thing to remind yourself when you prepare outside this scenario is you must assess the hydration status.
Okay.
Because patient have loose stool for 5 days, and with this vital sign, definitely you want to admit the patient, you say want to start hydration, but you didn't assess the CCTVR when you are examining the patient. Because for this kind of station, there is not much of sign for us to be detected, and definitely hydration status is one of the marks that the examiner is going to calibrate. So something that we cannot miss. If you miss that, it's very kesian because it's very easy to get the mark. At the same time, if you miss it, because we sometimes lose ourselves, then definitely you may miss it. Okay, so we're just going to discuss this. So the reason why I chose this cystic fibrosis post-lung transplant is because it came out in one of the exam in MRCP Island recently. So yeah, we know that MRCP Island are famous for getting surrogate without any sign. But I feel sometimes the scenario that they offer is something that is useful for us to learn. Therefore, I decided to actually put up this case. But I changed here and there. So there's no conflict in terms of using their exam question. Anyway, this patient have exertional breathlessness, but otherwise no failure symptom. I don't recall you assess or ask any of the failure symptom. Have you asked any leg swelling, any autopnea? No, right? Yeah, you routinely still need to ask because patient can have cor pulmonale with the underlying lung condition. So we still need to ask. Although you know that you're dealing more with the lungs, you still need to ask. Another thing is that patient got GERD, cystic fibrosis 2 years ago, and then and with all this medication, and you're very good. You managed to elicit that the patient forget to take the medication, not very compliant to the immunosuppression. Another thing that I feel is important for this kind of RESPI cases is the vaccination. It's very important. Examiners are quite particular. In MRCP, it's something that vaccination is something that we always need to ask. Because we know that if a patient with a lung transplant or any pre-existing lung condition came in infection, we are worried of all those severe lung infection which can be prevented. For example, like influenza or any other form of pneumococcal strep pneumonia. Those kind of infection, even COVID. So that's why vaccination you must actually ask for this kind of scenario and make sure it's up to date. And yes, you have excluded pneumonia to ask for travel history, sick contact, fever. And another thing is actually one of your differential diagnosis for this scenario should include bronchiolitis obliterans. Must include bronchiolitis obliterans, because actually if you look through the guideline in the NHS for post-lung transplant, if a patient have reflux esophagitis or GERD as well, they are predisposed to. Yeah, I think someone is not muted. Let me just. Yeah. Okay. Alright, I just muted it. So if a patient that have GERD on top of post-lung transplant case, they are very high risk to develop bronchiolitis obliterans, and this is also another fact that we should really address this. If we don't treat the GERD, they are actually had a very high risk to develop BO, or what you call a bronchiolitis obliterans, and this will actually cause graft failure. Okay, so and we are very good. I think you are really prepared for exam. You thought of asking the lymph nodes, examine for lymph nodes, because you're suspecting post-transplant lymphoproliferative disorder. Although you didn't name it, but I can see that you're trying to exclude the lymphoma and all those post-transplant induced hematological condition. So yes, you did very good. And probably another thing is actually you should mention that you want to recheck the patient SpO2 and to calculate the patient RR, because from the scenario outside it seems the patient is in respiratory distress. Okay, so another thing is yes, you have to also check for the clamshell scar as well. If possible, you see that the scar is there, you need to make sure you feel for it to make sure there's no infection. Although 2 years already is unlikely, but just for showmanship, we need to check the scar as well and to assess that, okay, so this is double lung transplant. And you examine the lung good. The reason you examine the lung for two things is look for any crepitation, and usually it's either fine crepitation or coarse crepitation, which may suggest bronchiolitis obliterans, like bronchiectasis kind of picture. And another thing is you want to rule out whether there's any bronchial bleeding, because you're suspecting pneumonia. And these two are negative, that makes both unlikely. And this kind of patient, you also need to check for cardio, especially loud P2, to suggest any signs of right heart failure. Okay, so the differential diagnosis for this is most likely what he have is chronic allographic dysfunction, chronic allograft dysfunction, secondary to missed medication, underlying cystic fibrosis. This is your full diagnosis, and your differential should include pneumonia. But for this kind of condition, especially on immunosuppression, you should not just mention pneumonia. You should mention pneumonia with a possible opportunistic infection. You should mention it can be bacterial, can be virus, or can be fungal. So viral commonly is a CMV. So you should mention that. If you mention that, it means that you are thinking that this is a immunocompromised patient with pneumonia, can be having OI as well. And the third differential diagnosis is bronchiolitis obliterans syndrome, and the fourth is a post-transplant lymphoproliferative disorder. So PTLD sometimes can also lead to BOS. Eventually, they also damage the lungs. And investigation, yes, you mentioned ABG. I'm looking hard. I'm anticipating you mentioned that, which is good. And then you also check the Fulbert count infection marker like CRP, ESR, lung function test is also another thing, X-ray, CT, and the FK level. I only prompt you and you mention, but this is something that you need to think about it. Any transplant patient, any medication, especially calcineurin, need to be monitored. Be it cyclosporine, be it a tacrolimus, need to monitor, because you don't want the level to be too toxic, at the same time too low. Too low, you need to check for the donor-specific antibody. For this patient, definitely need to check for DSA because there's a high risk. If a under-suppressed patient always has a risk to develop de novo auto-antibody like DSA. And this will eventually lead to graft failure or rejection even without treatment. Okay? And I ask you, how do you confirm a rejection? So the answer is very simple, biopsy. Need a biopsy of the lung. So like renal biopsy, how do we know that it's a rejection? We do a renal graft biopsy, right? Graft kidney biopsy. So same goes to the lung rejection. If you're suspecting lung rejection, the management is actually bronchoscopic guided lung biopsy. Okay? But not the open lung biopsy, just bronchoscopic lung biopsy. You should mention that. And you should also check for the sputum culture you mentioned. Probably a better one is also check for respiratory panel and PCR, because now you're dealing with maybe this is a OI related pneumonia. You're not very sure. The culture may not able to grow anything other than bacteria, so you may want to send to more workup. But mentioning respiratory panel shows that you are actually covering those virus and atypical types and the PCR. So it seems like, if you mention that, it seems like you are actually thinking that this can be OI, which is better. And the management, definitely pulmonologist, rehabilitation, admit, start oxygen, resusc, and consider adjusting the immunosuppression dose, and then to actually exclude other form of rejection. And for this condition, let's say that this is a rejection alone, you don't need to give antibiotic, but let's say that is evidence of bronchiolitis obliterans, or you're worried of that, we need to start some antiviral or antibiotic. Let's say the immunosuppression is actually under suppressed, so the dose is not adequate. Then at this acute stage, you may need to consider some Bactrim, some acyclovir prophylaxis, because you're worried the patient may progress. And then CLAD is something I will talk about it later. Those are the other treatment. And not to forget about vaccination. Remember all the respiratory condition mentioned about vaccination, chest rehabilitation. These two are the must. Even if you don't have time, I routinely mention about that. Also is good enough. And then concern, are my lung failing? Yes, there's a possibility. Can the reflux symptom worsen my lung condition? Definitely. So another learning point from this scenario is that if a patient with a post lung transplant, although it's very rare we will get this kind of scenario in our exam, but please bear in mind that a lung transplant patient, if we have reflux symptom, you should treat the reflux symptom. Another thing I didn't mention is to sub PPI for this patient to really treat the reflux symptom and counsel for non-pharmacological intervention, for example, prop out when feeding, and then avoid large meals, eat small and frequent meals, and avoid those spicy and then those lettuce, things that may worsen the broadness. Do I need another surgery at the moment? No. Okay, so just going to tell this share about this lung transplant rejection because it's very rare in our setting. Unless we go to UK, then the lung transplant is something that quite common, can come out in exam. But in our local setting, I was told that previously in the past there is about 3 to 4 patients with lung transplant across the peninsula. But generally we seldom see them in the recent years after the COVID. Don't know whether they still survive or they are already too old to come for exam. But please bear in mind that always they may import some patient. So always prepare for everything. So for this lung transplant rejection, usually there is two. Either it's acute cellular or antibody mediated and chronic rejection, what we call as CLAD. Okay, so acute rejection basically is T cell. When we talk about rejection in any transplant, we talk about antibody mediated rejection or T cell mediated rejection. So either it's a B cell or T cell So if it's a T cell rejection and the risk factor is usually like reflux and they're not on medication, so this is usually during the first year post transplant. This patient is already 2 years post transplant, so unlikely to be acute. Okay, but you can see the risk factor are generally almost the same. And then it's to monitor usually during the acute stage and may need to give remember, just like renal transplant, for this kind of rejection, T cell mediated rejection, we need to give ATG or anti-thymocyte depleting agent. So the management is to give ATG. And then tuzumab or sometimes there's another drugs, usually they are less potent. The more potent one is the ATG, the thymoglobulin depleting agent. Okay, this is for T cell. For B cell, how we treat, generally both also may require steroid but the T cell one you tend to treat with ATG, and the antibody mediated one, there's a lot of options available. You need to methotrexate the patient, plasmapheresis, IVIG, Rituxan, and may even consider chemo agent like bortezomib, Velcade. So antibody mediated can occur anytime, and usually they will be sensitized for some reason. For example, if the patient if it's a lady, patient may get pregnant. After pregnancy, may develop SOB. Then you need to think about can this due to previous sensitization from the pregnancy. So sensitization is something that we are very particular in transplant patient. Let's say you have to ask whether they have received blood transfusion, whether they have any pregnancy. Let's say it's a female, and sometimes sometimes may need to know about the donor status. But usually they won't know, as a patient they won't know about the donor status, whether they get any like ABO incompatibility, HLA, those are very advanced for them. So whether or not necessary to ask, but you can at least ask about transfusion as well as the pregnancy. Let's say it's a female, and then this can generally develop anytime. Okay, how about chronic rejection, CLAD? CLAD is usually usually they will have some form of scarring. So CLAD tends to develop to become bronchiolitis obliterans, and we know that in a transplant patient, if you develop bronchiolitis obliterans, then generally it's irreversible. So we don't want bronchiolitis obliterans. We want to intervene early to prevent the progression. So you can see that the chronic rejection, which is likely in this patient, previous acute rejection, no, this patient don't have. Infection, possible. Patient have reflux and patient is not taking medication as prescribed. So these two are the risk factor that the patient has. And usually chronic by definition from the lung transplant perspective is more than 1 year. And then usually to prevent other types of rejection, you can consider some antibiotic like azithromycin to cover for atypical infection prophylactically. Montelukast and ECP is what we call as extracorporeal photopheresis, which is not available in Malaysia. Something worth to know just for the chronic rejection. But generally it won't come out in exam. This scenario came out, the reason I chose this scenario is because I feel that if MRCP Island can come out with this scenario, there is also a tendency that MRCP sometimes may also choose a less typical scenario that we less anticipated. So we have very familiar with renal transplant. Liver transplant, I believe everyone also got a bit of overview already. I think we discussed that during our the first few sessions of our campfire. A lady with underlying lung transplant on cyclosporine came in. I can't remember the scenario. Something like not on cyclosporine, on tacrolimus, developed hair loss. It was a scenario same as the last exam. You'll be shocked that Terengganu exam center, they actually managed to find a liver transplant patient to come out in the exam, and the stem was alopecia. Yeah, so alopecia was the stem. Yeah, someone else is interfering. Okay, I'm just going to mute that. So that station is a BCC, is a case of hair loss, and the patient have underlying liver transplant on tacrolimus. So the diagnosis was tacrolimus-induced alopecia. And other differential can also be alopecia areata, autoimmune association, blah blah blah. So there's a lot of other differential diagnosis need to exclude, like thyroid as well. So, but general clue is that if imagine that if a new center came up with liver transplant, why not a lung transplant? Because lung transplant hardly ever come out in our center nowadays. So this is something that the reason I put up this case is to discuss about it. Okay, so the second case, you got two things that you miss mainly. First is you didn't ask about past medical history. Do you remember?
Yeah.
Yeah, it's important. You know that the patient is a nursing home resident because I told early, but you need to know why the patient is in nursing home lah. So patient is in nursing home because after stroke actually have weakness and therefore cannot be taken care by family members. That's why I went to nursing home. And if you know that patient have stroke and patient is on PPI as well, then you know that the risk factor to develop C. diff is even higher. We know that what is the risk factor to develop C. diff in a patient? Do you know? You have mentioned a few just now.
Old age.
Old age, elderly, yes. Number one.
Taking PPI.
Correct. Number two.
Then antibiotic.
What kind of antibiotic?
Cipro.
Okay, correct. Other than Cipro?
Penicillin type.
Penicillin. I mean, penicillin is very broad lah. Generally, if you take penicillin alone, shouldn't cause the C. diff lah.
Clarithromycin.
Clarithromycin, correct. Any other medication? So the 4C lah, I used to remember 4C when I go for exam, and generally it's based on the ID teaching as well. So 4 types of antibiotic that can predispose to C. diff is actually 4C. First C is, we know Cipro is there, clarithromycin is also another one. The third C is very common drugs being used, which is cephalosporin, particularly the second and the third generation cephalosporin. Okay, and the last C is actually your clindamycin, which is hardly used, but it's quite frequently used in orthopedic. Let's say got some bone infection, they will give clinda on top of that. Yeah, so this 4C is the common antibiotic which can induce C. diff. Other than antibiotic, any other risk factor? You have mentioned 4.
Hospitalization.
Sorry?
Hospitalization.
Hospitalization, healthcare associated in the setting of nursing home or even hospital, right? Any other risk factor?
I'm not sure.
Actually, this patient also has, just that you didn't ask. Patient is on rice tube actually. So long-term rice tube also predisposed to C. diff as well. Okay, so yes, this scenario you immediately know this is acute diarrhea, relief with fasting, no blood, you're not dealing with dysentery or colitis, but probably it's also good to ask about to screen for proctitis symptom. You want to ask any urgency and also any tenesmus, which is want to pass motion just after passing motion, and then incomplete sensation of emptying. You should ask about proctitis, because we don't know, sometimes elderly may have some form of proctitis from some other causes. And another thing is that definitely this kind of scenario you need to ask about past medical history. You don't want to miss a patient that is, for example, post chemo or post radio and develop some radiation proctitis and develop acute diarrhea. So something that we need to mask. So the tip is that before you examine patient, you should ask. You have, after you have done a HOPI, you should really ask for past medical history and drug history first before you examine patient. That's the baseline, I feel. You can skip the social history later on after you examine patient, but you really need to ask about past medical history and drug history, or sometimes even diet history, before you examine the patient. Because without doing that, you will miss things. For example, in this patient, you will miss to assess hydration status, and then you just rush in and then you want to check the abdomen. After abdomen is normal or even hyperactive bowel, nothing much, then you don't know what else to check. Maybe you want to check for pneumonia. That's why you ask to listen to the lung, which is okay. And if you have time in this patient, because you didn't manage to elicit the patient is actually bed bound and then shook out before, in this kind of scenario, we also need to rule out whether there's any sacral sore. Very commonly we do in a clinical setting, but in exam we never thought about that. So you ask whether patient have any evidence of pressure injury. You want to check for pressure injury. Just mention that, no need to check also, never mind. Because sometimes we know that if patient is on Pampers, and then the hygiene may not be good, and the patient may really develop infective colitis from there. So the calibration would be first to check for the abdomen to look for any evidence of warning sign, which is the bowel sound, whether there's any sluggish bowel sound or hyperactive, and the hydration status is the one. So you should also reinforce the examiner saying that I notice the blood pressure is a bit low and the heart rate is tachy. Can I want to repeat the blood pressure, I want to repeat the vital sign to look for signs of hypovolemia. Just mention that. I know some examiner may get irritated when they say it's already mentioned outside. I mean, some old examiner, they don't want to give you any reading, they will mention that to you. But it's good to mention that, because the moment you mention that, it shows that you recognize that this is also the sign in this scenario. Okay, you recognize that this is possible hypovolemic shock. You recognize that. Okay, and the diagnosis, yes, C. diff associated colitis. Second possible diagnosis is actually the antibiotic induced diarrhea after the Cipro. And the third one is infective diarrhea. You have mentioned that. But this scenario, because you didn't mention about hydration status, you didn't mention patient is in shock, therefore you did not think of ordering VBG and lactate, which is very important in this scenario. That's why you mentioned renal function, I think, and the inflammatory marker. And because of this exam nervousness, you forgot to know how to diagnose C. diff. Actually, I think you know. It's just to get the C. diff toxin and antigen from the stool culture. So it's a stool sample, particularly look at C. diff toxin and also the antigen. For this particular scenario, we know that C. diff can associate with pseudomembranous colitis, and therefore it's important for you to at least mention about abdominal X-ray. You don't want to mix a dilated colon, or worse, later there is any perforation. So that's why sometimes if the abdominal X-ray is suggesting a dilatation, you may want to proceed with CCT abdomen. Okay, so management is education, counseling, multidisciplinary, admit ward, resus, fluid, and then so this patient, if it's C. diff and hypovolemia, is already considered as life-threatening C. diff already, because the stool also more than six times. We know that actually 3 to 6 times is moderate, less than 3 times is mild, and then more than 6 times is actually considered severe. And if the patient is in shock, definitely is considered as life-threatening already. So definitely you must mention isolation, oral Wenco, or second line is a fidaxomicin if the hospital has the facility for 10 days. Okay, the dose is quite static lah. No need to adjust with the antibiotic of the renal function or anything. So you can mention about that if you know the dose. If you don't know, it's okay. And if there's any evidence of perforation or anything, refer to surgical team. If it's a refractory, you may consider fecal biodata transplantation, which is literally implant the other people's shit into the patient gut. Okay, but this is on the refractory cases. Okay, so a bit on the C. diff. This is a new guideline. You can see that it's out in 2021 July in NICE. You all can search the Google and for this guideline. It's a very long guideline, but generally they give this very beautiful chart, a summary chart of what the guideline says. So I'm not going to go through, but basically you can see that for this condition, sometimes we need to review the medication to discontinue, like PPI. We know PPI is also predisposed to that. And then, like for example, dehydration, like NSAID, because most of the time they may develop some AKI. Need to avoid nephrotoxic drug as well, and do not offer anti-motility agent. Okay, and there are some drugs that we don't even have, so just forget about it. And consider fecal microbiota transplant for recurrent episode infection after 2 or more previous episode. So you can see that if patient have first C. diff, yes, you can treat oral. Second episode, if we still not respond, you have to consider transplant with other people's shit already. So you must have this idea in the back of the mind when you treat C. diff. And offer oral antibiotic in adult. The young people and preventing no need to see lah. But basically you need to make sure patient hydration status is good. Okay, and this is like a community setting that refer to hospital. Okay, so next thing is the second page is the antibiotic options. So in the past, we differentiate the C. diff infection treatment to mild, moderate, severe, life-threatening, and it's either Vanco or Vanco plus fragile, IV fragile. It's actually IV fragile. So you can see that nowadays the new guideline changed in terms of the treatment for the first line. Regardless of whether it's a mild, moderate, or severe, your first line is still oral Vanco alone. And if the oral Vanco is not effective, you can consider switch to fidaxomicin. If let's say the hospital has it, I think even UM don't have it. I don't think other hospital will have it unless in private lah. So, but it's something that in the guideline we should mention. Second line option is a fidaxomicin. But let's say both first and second line are ineffective, then yes, we should consider adding IV fragile. So you can see that nowadays the guideline, not for severe C. diff, you should always start Vanco and fragile. No, the management is actually still oral Vanco or oral fidaxomicin. Let's say still not responding well, then only you consider to add on IV fragile. Okay, and there is some prophylactic to prevent recurrence. There is something called recurrence and something called relapse, depending on the duration. Generally, anything less than 3 months is considered relapse, and anything more than 3 months is considered new episode, so it's considered recurrence. And the life-threatening condition, definitely you need to give both. So you can see the guideline actually changed slightly, but generally the dose also differs. So example, when you're talking about severe or not responding, you are actually giving higher dose of IV oral Vanco, 500 mg QID instead of 125 QID. So if it's severe, still the same, start with 125 QID for 10 days, not responding, may consider switching fidoxo or add on fragile. But let's say patient develop life-threatening, like this patient is considered life-threatening. So you need to start both, and you need to give high dose Vanco, not just 125. Okay? So I hope it's clear. Any question?
No.
No, okay. So we will leave to the last candidate, Jeremiah. Are you ready?
Right, yeah, ready.
Okay, so I will give you just 2 minutes to prepare for the last BCC, and we will call it our day. Now it's 9:30, the timing is good. So we will start when you are ready. Okay?
Okay, can.
Okay, but I'm not ready yet, unfortunately. Okay, let's just start. Okay, time's up. Dr. Jeremiah, this is the patient, Madam Yusma. Please start.
Hello, hi, good evening, Madam Yusma, Dr. Jeremiah. I'm one of the doctors here. So, is it okay if I just talk to you and just do a quick examination of you?
Sure.
Yeah, I just got it. So, what brought you to the clinic today?
Yeah, so I've been having my upper jaw pain over the left side for almost 3 months now, and I feel very discomfort. Sometimes you feel very numb, and then also got some unusual sensation. Sometimes you got some unpleasant taste over this area. I'm very concerned.
I see. I'm so sorry to hear about that. How did it start? Did you hurt yourself? Did you injure, fall, hit yourself in that area?
Yeah, so I don't have any problem in the past until 3 months ago. I went for some dental extraction because my left upper teeth was actually loose. So the dentist removed the teeth, and after the removal of the teeth was quite okay. I mean, I didn't experience much symptom. Then slowly I realized that I have this unusual kind of sensation and numbness. I also have a bit of other loose teeth as well in the surrounding area that was removed .
I see. Okay. Have you noticed any swelling or any in the area of the teeth that you've extracted or anywhere else in the mouth?
I don't know. I can show you, doctor. This is my teeth. This is where they remove my tooth, but here I feel my teeth here is already loose.
Okay. And you mentioned that you have pain whenever over in the jaw. Is it related to any particular activity, such as, for example, when you're eating or swallowing?
Yeah. I feel the pain is more when when any food in contact of this area lah. But generally, even if without eating, also I'm experiencing pain.
Okay. Have you taken anything to help the pain?
Not really. I've tried with Panadol, but it doesn't really help much.
Okay. And how has your appetite been, Miss Yusma?
Yeah, my appetite has been reduced because of this pain.
Okay. And apart from this pain in the jaw, do you have any other problems that you wish to tell me about? Do you have any pain, for example, when you comb your hair?
No. But I do have some. I feel like I do have some oral mouth sore as well, especially upper and the lower part of my mouth.
Okay, sure. And any other rashes, for example?
No,
Okay. How has your weight been?
my weight has been quite static.
Okay. Madam Yusma, do you have any medical conditions that I should be aware of?
Yeah, I have breast cancer. I'm a breast cancer survivor. I underwent the right breast removal lah, and also did some chemo and radiotherapy 1 year ago.
Okay, and are you under regular follow-up for this? Are you still seeing the cancer doctors?
Yeah, I must see under the doctor follow up because the doctor told me I got this high calcium level in the body due to this cancer lah. So I'm under the breast surgeon. I'm still on this medication called tamoxifen 20 mg OD. I'm also taking metformin as well. I got some diabetes. Other than that, I also on this IV injection lah for the high calcium level every 4 weeks.
I see. Okay, all right. And do you happen to smoke, Madam Yusma?
No, I don't smoke.
Okay. Do you take any other medicines apart from that given by the doctor? For example, any betel nuts, for example, traditional medicines?
No.
Okay, all right. Madam Yusma, is it okay if I very quickly just examine you?
Sure.
So I'd like to get a look at the patient's oral cavity. So I noticed that there is some loose sockets. Any lymphadenopathy?
No cervical lymphadenopathy.
I'd like to inspect the mastectomy scar to look for any recurrence, any axillary lymphadenopathy.
Good. No.
Okay, I'd like to inspect the jaw itself, the jawbone itself, for any swelling in the jawbone.
There is no swelling, but there is a tenderness when you palpate the upper left jaw.
Okay. Any temporal artery tenderness?
No.
Okay. Madam Yusma, what do you work as?
I don't work nowadays. I'm actually after I survived from my cancer, I just rest at home.
Okay. And how is this all impacting you?
Yeah, I can see that for the past 3 months, my appetite has been reduced because of this pain. I feel very troubled by this because it seems like even the mouth sore that I mentioned to you, upper part and the lower part, it doesn't heal much. I'm very worried.
Yeah, I'm sure this is very concerning for you. So is there anything particularly you're concerned about? Or what do you think might be the cause of this problem?
Yeah, I don't know, doctor. Can this be due to my breast cancer that start to spread to the bone, especially my jawbone?
Yeah, sure. I'm sure that that's something that you are worried about. But taken that you are under regular follow-up from the cancer doctors and you do not have any other evidence to show spread from the cancer, it is quite likely that the cancer is under control. And I think it's not that. I mean, it could still be a possibility, but I think it's a bit less likely that the cancer has spread to the bone. What I suspect, Madam Yusma, that you're having is what we call some necrosis or injury to the jawbone. Don't be too bothered about the terms.
Okay.
But sometimes this can happen with prolonged use of this calcium-lowering medicines that the doctor has put you on. Are you following me so far?
2 minutes left. Yes, doctor. So this is due to the medication?
It is one of the possibilities with long-term use of this medicine that you are taking currently.
Oh, do I have dental infection? Can this be due to the infection 2 months ago that's not healing and then now it start to form some collection inside?
Yeah, that's definitely something to consider. And it has been shown that this kind of dental procedures on top of the medicines do predispose you to develop this problem with the jawbone. So what I would like to get done for you is that I'd like to get you seen by our dental surgeons who will assess you further, and they might need to talk to you further about further interventions for this problem of yours.
Oh, good. So, doctor, I want to know, you said this due to some bone issue. Can this condition recover with time?
Generally, I think this would need to be discussed together with your cancer doctors. You might need to temporarily hold off the medicine for the bone, but at the same time, there also needs to be some other discussion about what else can we put you on. But generally, with stopping the medicine, hopefully, and if the problem with the jaw is not too bad, it should recover with time.
Oh, okay, doctor.
Is there any other things that you are concerned about? Or?
No. That's all, doctor.
Okay. Thank you so much, Madam Yusma.
Yeah, thank you. So, time's up. So, Dr. Jeremiah, can you tell me what is your working diagnosis and your differential?
Okay. So, Madam Yusma has some jaw pain after a dental procedure 3 months ago. She does have a history of taking bisphosphonates for hypercalcemia post-malignancy. So my differentials for her is osteonecrosis of the jaw. I did look into other possibilities like metastases to the jawbone, or any osteosarcoma, or any local infections like gingivitis, or any problems with the TMJ joint.
Okay, good. How do you investigate this patient?
So I like to order an X-ray of the jawbone. And then I like to do some blood tests, doing a full blood count, renal function, a calcium IPTH level, and a phosphate level as well. And then I like to do some inflammatory markers as well, in ESR CRP, because infection is still something to consider.
Any imaging you want to consider?
OPG, I think that's what it's called.
OPG? What's that?
I can't remember the full name, sorry.
You don't want to do any X-ray?
Yeah, it's a X-ray of the jaw.
Okay. How will you manage the patient?
So this patient will need to be referred to a dental surgeon urgently, and then we would like to give her some painkiller for management of her pain, and like to have a discussion with the oncologist with regard to her bone protection agent.
Will you consider stopping the bisphosphonate?
Yes, the bisphosphonates would need to be stopped for the time being.
While waiting for referral to the dental team to review, any other things that you can do for her, can offer for her?
I think advise her on proper dental hygiene and adequate pain control.
Okay, good. Yeah. And then in terms of the refractory cases, if it's not healing, what else can be offered?
Sorry, I'm not aware of that.
Okay, we let the dental decide now. Okay, time's up. Okay, generally you do very well. Very good. Excellent. So I think you are prepared for exam now. Your timing itself is already on par as compared to the last time we practiced together. Your timing is very perfect already. And the reason why I end early is because actually there's about 30 seconds left, but the reason I end early because in real exam you spend some time to examine the patient oral cavity, move here and there. So those are the time that will be wasted. Instead of yes no question to save the time. So but generally your timing is good. You managed to examine the patient at 3 minutes and 30 seconds, and you managed to you examine only probably about 30 seconds, but generally in the exam you may use about 1 minute. But generally your approach is good, and then your differential analysis is also good. Okay, so I got nothing to add on actually, because most of the thing you have asked. Probably the only thing you can do better in the history is to ask about the fever. You didn't ask me about fever. I didn't recall you asked me anything about fever, and also any discharge coming out from the oral cavity. Hello, Jeremiah, can you hear me?
Yeah, I can't recall also, I think.
I remember you didn't ask me about that, because definitely dental abscess or any form of dental infection is actually likely in this case. So definitely this is something that we need to exclude So yes, you thought of the diagnosis. I think this is actually not an easy scenario, to be honest. If you don't know this osteonecrosis of the jaw, you may miss the diagnosis. Okay, but generally you are good. You didn't miss it, and then you know what you're looking for. And yes, another differential diagnosis is called temporal mandibular syndrome. Okay. So other than that, I got nothing to add on like I say. But in terms of management, we need to consider to mention the stopping bisphosphonate for a short duration. Probably that will be the first management. If anything, if a drug is causing any side effect or any harm, then probably we should mention that at first lah. Other than stabilizing the patient and the ABC thing. But this patient doesn't need much stabilization. This patient generally needs to stop for a while, and then need to refer to oncologist or even endocrine to ask for any alternative therapy for the hypercalcemia. So another thing is that the dental hygiene need to be mentioned, and you can also mention about antimicrobial mouthwash, and also some antibiotic if necessary. Sorry, some people are finding me. Okay, so other than that, actually, this patient I calibrate it as non-smoker lah. But if it's a smoker, then it's another risk factor to develop ONJ of the jaw. And minor. So the principle, the reason why I ask you in refractory cases, what are you going to do? So definitely this is not our decision. But the idea of this osteonecrosis of the jaw is you try not to operate, because we know that this is something like a calcified uremic arteriopathy lah, which is the I can't remember the name suddenly. But anyway, this is something like a wound that is non-healing, and definitely you don't want to manipulate or even do anything unnecessarily unless it's really, really desperate. So the idea is actually to preserve the dental root, and then to maybe just do a regular dressing and also a dental hygiene in order to reduce that. Because usually osteonecrosis of the jaw does not cause pain. The bone are generally painless, no receptor. And the problem with that is when it get infected, only will start to have pain. So that's the question of skip on, got people coming. Wait Okay, so the idea is actually not to do any major operation unless it is really advanced, like refractory. Then may need to consider to resect the necrotic bone, or else we just let give some time for the bone, for the infection to resolve, and then it will generally become painless, and generally it doesn't disturb much. And whether or not you can restart back the bisphosphonate, it is very debatable. If you read through the guideline, even the up to date as well, some people they recommend to increase the interval of bisphosphonate but did not stop. Some people they stop for a short duration, or some people change to other alternative agent, like for example PTH analog, but it's very expensive, you cannot afford. So generally there's no definite guideline, but general guideline is actually to stop for a while, stop the bisphosphonate treatment for a while. Okay, so that's all for today. Is there any other question for me? Jeremiah, you okay, right? No question, right?
No question, but honestly, I didn't know what I was talking about. I've never seen an osteonecrosis of the jaw before.
Yeah, actually, you can see that generally
it's very rare.
ONJ is rare because we did not actually encounter that. The problem is that because it's more prevalent in the patient who is actually hypercalcemic of malignancy. So usually the dose that we give for the Jerry patient, for the osteoporosis prevention is quite low. I mean, we also give the same duration, but generally they don't develop that. The study has shown that the risk factor to develop ONJ is those that is associated with cancer, for not sure what's the pathophysiology, as compared to those on treatment with bisphosphonate for osteoporosis. They tend to see that higher in those with hypercalcemia related malignancy. So yes, we seldom see that because we mainly dealing with those patients with osteoporosis. But according to literature review, actually the prevalence is not that low. The reason why it's not being detected is because most often the patient have not much symptom to complain. They may have ONJ for quite long until suddenly that empty socket or something near the surrounding get inflamed and get infected, and that's the time that they seek treatment. But most of the time it does not cause much symptom. So that's why this disease is not being recognized easily. So it's so-called rare. Okay? Yeah, any question? So I think today is the last session that we all have before our Diet 2 colleagues going for exam in like 5 or 6 days time. Correct, Jeremiah?
Correct. Very scary.
Penang, right? You're Penang, right?
I'm going to typing.
Oh, typing. 21st or 22nd?
22nd.
22nd. I see. Penang is also 21st or 22nd, right? If I'm not mistaken. Yeah.
Yeah.
So, yes, all the best to everyone who joined this and whoever going for exam. I hope you all will pass because the idea is to know how to tackle the exam. And generally, if you are more comfortable, like what Jeremiah did just now, he actually did excellent, you know, he can get full marks. But he don't know what he's doing after he come out for exam. This is something usual. If you have practiced enough, you will realize that exam very fast. Suddenly, haven't really thought about it, then finish already. Then you don't know what happened inside. But generally, you will know if you do well. If you feel like you are not stucking much, and then you can answer the question, and then examiner didn't prompt you much, then you know that you are on the right track, Okay, so I hope all the best for everyone. If anyone have any question later on or anything, anytime, can just post in the group, So we'll try to answer. Okay, so this is a short session for tonight.